I'll be speaking really directly about common disorders of pain in primary care. And actually, this slide probably could be a bit updated, but I'll just point out that my background is in primary care. So when I talk about common disorders in primary care, this was really my life for 27 years before I joined the University of Washington. I've been focusing almost specifically on pain. No conflicts of financial interest, and I will be mentioning off-label use of medication. So my general objectives today are going to be to have you know some characteristics of commonly managed primary care pain disorders, be familiar with the non-drug treatment options, and then in response as well, be able to introduce effective pharmacological treatment approaches to these common primary care pain disorders. I've broken them up into 6 general reasons of pain, and I find this very useful. You in your own practice and your own style will group or lump as you see fit, but breaking it into spinal pain, and we do have a case later today about spinal pain, which will bring out a lot of salient topics as we proceed with our discussion. Musculoskeletal pain unrelated to the spine, headache pain, neuropathic pain conditions in general, then visceral pain syndromes, including abdominal and pelvic pain, and then finally widespread and regional pain, which by and large represents what we often cluster as fibromyalgia. So that'll be our general themes, and I'll do my best to weave them together from that format. So spinal pain, I've categorized into 3 broad groups. Apologies to the spine surgeons, neurosurgeons, and orthopedic surgeons. But as a primary care person, I'd say, is this coming from the neck and or low back? And is it related in part to the disc or narrowing of the disc space, which would be stenosis, or degenerative arthritis in the spine, or pain in the neck or low back related to predominantly muscular or myofascial components. The second category is radiculopathy, which again is generated by the spine. So this is direct impingement on a nerve root, either from the neck or low back, that's producing radicular pain. And that'll be our case later today, will be a radicular pain component. And then failed back surgery syndrome, which represents patients who've had spine surgery. The surgery went well. Anatomy looks fine, appropriate for post-spine surgery, and yet pain persists, which is, again, a very difficult and often seen challenge because the surgeons send them back to we primary care docs to take on, and we don't have a clue as to why they hurt and what to do next. So the common themes are imaging is often not helpful. Important point here, you cannot diagnose pain from an X-ray or an MRI. Terrible X-rays could be not associated with pain. Normal X-rays can be absolutely blindingly painful for the patient. That applies to not only plain films, but also MRI. Another theme is that radiculopathy, or referral of pain down an extremity, may not follow a strict dermatome, which becomes difficult for us to understand. And importantly, that if there are progressive motor or sensory deficits, a specific intervention is typically called for. So careful physical exam and then follow-up careful physical exams to map the deficits becomes crucially important. Another common theme is that nociception, meaning direct irritation of the end organ, the free nerve ending of the nociceptors, may not be present. So we may not see active input into the pain system through nociception, yet pain may still persist. And this moves us into the realm of central sensitization, and probably plays a large, in fact, a dominant role in failed surgical spine syndrome, for instance. So some understanding of central sensitization is very important to be able to make sense of what we're seeing as diagnosticians, and also to be able to make sense for our patients so they can understand why they hurt in the absence of any ordinary cause and effect. This is broken, and therefore this hurts. For all spine pain, return to activity is crucial for quality of life and for the patients to manage pain. Overcoming fear of pain, avoidance of use because of fear of pain or kinesiophobia, and then secondary deconditioning is a common theme across the board for all our pain states, but particularly in spinal pain. And we should avoid treatments that reduce energy and motivation. And these are the sedatives and the opioid agents. And finally, chronic opioids, especially high dose, may contribute to worse outcomes, and the data certainly supports worse outcomes in terms of adverse events, risks, but we also know that function typically will decline with these drugs. Quality of life typically will decline. So one of the most common treatments that we have historically come to, it may be actually a treatment that leads to worse impairments rather than patient improvement. So if we break out in spine treatments, non-pharmacological versus pharmacological medication management, stressing again that non-pharmacological management is our first step. Exercise, structured rehab as directed by a physical therapist or occupational therapist, on land or in water, or typical PT or aquatic-based physical therapy. Cognitive behavioral therapy is perhaps the most crucial component of pain management in all the domains we'll talk about today, and especially in spine pain syndromes. Sleep management, dietary hygiene, very important. So patients with significant obesity are certainly at risk for putting more loading of their spine, and perhaps inflammatory diets or high glycemic diets may be triggering more intense experience of pain. There's value of hypnotherapy, value of acupuncture, and a variety of whole host of other treatments that we put into cognitive behavioral therapy, such as mindfulness training, relaxation, and the like. In terms of medication management, if pain is generated by active nociception, because NSAIDs are working on nociceptors and the response of those nociceptors to outside stimuli, if they are present, NSAIDs do play an important role. Steroids, oral, may play a role, or image-guided interventions may also play a role when there's an inflammatory or swelling associated with injury at the local site, and if that site can be localized. Tricyclic antidepressant drugs, or TCAs, or SNRIs, that's serotonin norepinephrine reuptake inhibitors. So the norepinephrine component matters. Hence, the SSRIs do not appear to have significant role in management of pain or sleep in these circumstances, but may improve mood. Anti-epileptic or anticonvulsant drugs do play a role in management of pain that has particularly neuropathic characteristics as well as central sensitization. And in exceptional cases, opioids, and rarely at high dose, and it's not clear that high dose should ever, except in really exceptional cases, be considered for management based on the caveats I provided earlier, in that evidence supports poor quality of life, reduced quality of life on the higher dose, and reduced function on those higher doses. So if we're talking about musculoskeletal conditions that are non-spinal, osteoarthritis, knee, hip, other weight-bearing joints, or post-traumatic arthritis, foot, ankle, associated with loading, but also post-traumatic injuries, shoulders, elbows, elsewhere, are common primary care issues. Inflammatory arthritis, such as rheumatoid arthritis, or spondyloarthropathies, or the tendinopathies or other enthesopathies. Again, though rheumatologists may have a prominent role in the management of most extreme inflammatory arthritis, I'm quite certain that most of the primary care folks connected here today are managing this perhaps with a remote consultation from a rheumatologist, but are managing it yourself. So again, common themes. Osteoarthritis is normal. It's part of living in a gravitational field and having a skeleton that supports us. Osteoarthritis typically does not hurt. There may be some intermittent pain with use, but it is not a typically disabling condition which requires pharmacological management as a routine. Structural deformity will contribute and may increase pain on top of that. So being able to work through structural deformity, sometimes surgery and sometimes other aids and splints and devices can ease some of that structural deformity. That may increase the pain and limitations. Obesity and deconditioning, again, like spinal pain disorders, needs to be addressed. And if there is an active inflammatory component, then NSAIDs may help. They may not once the pain is fully centralized. Return to activity is crucial for quality of life and to manage pain. This is identical to the spinal pain component, and again, identical. Point 6 is chronic opiates, especially high dose, may contribute, again, to worse outcomes. From a primary care treatment portfolio, what might you offer? From the pharmacological side, osteoarthritis, acetaminophen has some role. NSAIDs appear to be more effective. Opioids are more effective for knee osteoarthritis than NSAIDs or acetaminophen, but these, if necessary, need to be managed thoughtfully, demonstrating improvement in function, careful and attentive to risks that are associated with these opioids, particularly since osteoarthritis is a problem in older patients and becomes progressively more so in older patients, and those are the group who have the highest risks of falls, cognitive impairment, and interference with general function in general in the setting of opioids. So that's a skill that will require continuous monitoring. For acute and subacute trauma, ice, alternating with heat sometimes, typically in the acute phase, ice, anti-inflammatories, using them topically or on the skin, the transdermal products may play a role if the injury trauma is at a level where the anti-inflammatory transdermally can get, and that's basically under a centimeter. So use on backs and shoulders makes no sense at all. It's an expensive way to deliver an already expensive drug, and you're getting about 10% absorption through subdermal capillary flow. So application of the transdermal products to knuckles, hands, wrists, feet may make sense because you're getting it into the synovium, but basically think more than a centimeter, you're not reaching your target. Again, ice heat, avoid mobilization. Lots of controversy in practice about do muscle relaxants work. I will add to that with the definitive statements. They do very little. They relax the patient, calms them because they're sedatives. They relax us because we get to do something. We don't like to be able to not write a prescription that we think will help relieve pain in patients. But certainly with long-term and chronic conditions, and I'm speaking here to acute and subacute, they may play a role for short-term use. Cyclobenzaprine or Flexeril, widely prescribed in the acute and subacute setting. And don't forget that cyclobenzaprine is a tricyclic antidepressant molecule. It likely works as a tricyclic antidepressant molecule, but it does not appear to have any antidepressant effects. So my colleague, Dr. Mark Sullivan, has said it is a tricyclic non-antidepressant drug simply because it's not been studied, and to get doses up high enough to have antidepressant effect, your patient will be so sedated and so anticholinergic they won't be able to function. Again, rarely opioids, but in severe or at least moderately high severity pain may be useful in acute and subacute trauma to allow the patient to re-engage in activities of daily living, activities associated with perhaps earning an income, getting them to work, and participating in a rehabilitation plan. But long-term chronic use of opiates, again, does not appear to be as effective as we once thought. For inflammatory arthritis, again, NSAIDs, they are pretty good, but if a patient has a spondyloarthropathy diagnosed, they are not going to be nearly as effective as disease-modifying anti-rheumatic drugs or DMARDs, and that's out of the scope of my practice. I'm reliant on rheumatologists to help me get that going. But in rural practice, where rheumatologists may not be available, some knowledge about how to prescribe and manage DMARDs would be very reasonable, because, again, if you treat the nociception, pain will subside in most patients. And patients who have centralized pain will have a reduction in the input into the sensitization process that's being driven from the periphery by that active inflammation. So treating nociception when it is possible is a high priority in the management of pain. So DMARDs are very, very important and should be strongly encouraged and support as available by rheumatology as necessary. Corticosteroids, when indicated, then again, chronically is a potential disaster as far as osteoporosis, avascular necrosis, diabetes, weight gain, muscle atrophy, all the things you know well, but may play a role in pulse fashion. Physical therapy, occupational therapy, again, play a role by moving the joint, keeping the joint moving. You're going to do a good service to your patients. And again, rarely opioids, again, if demonstrating improvement in function and improvement in quality of life at low, moderate dose are quite appropriate. Headaches, one of the number one problems that you're seeing in your clinical practice. You're seeing some migraine. Migraine represents about 10% of office visits in primary care practice. Higher prevalence in women, particularly post-menarche. They seem to subside post-menopause, but may not. So I had patients tell me that menopause was really good in some respects because the headaches finally went away, but the menopausal symptoms were no sweet breeze either. But they clearly have cyclic patterns. Migraine is characterized by episodic presence. So if the headache is daily, it is not migraine. The migraine may have evolved into what's currently called chronic daily headache, and that is often driven by the use of the medications we provide because of the sensitization that's caused by the medications themselves. And then there are the musculoskeletal headache conditions, and that would be temporomandibular disorders, a headache that's driven from the neck, so cervical spine arthritis that's referring into the head can then generalize further, and then what are called tension type or muscular headaches. They're more likely central sensitization driven, but they again have a musculoskeletal component associated with them. So just a quick anatomy review that I found useful when explaining this to medical students. Where do migraines generate from? Well, they generate at the periaqueductal gray, which neurons in the periaqueductal gray fire and connect directly to the trigeminal nerve. And the trigeminal nerve innervates the meninges and the vascular structures of the head. So basically, pain in the head is mediated through the trigeminal nerve, and migraine starts as a neurogenic event, which is why the triptans work, because they reduce the activity of the periaqueductal gray serotoninergic system, and why our anticonvulsant drugs may play a role, do play a role in preventing migraine because of the reduction in activity of these neurons, the ectopic activity that's stimulated. And then the vascular events are secondary to the neurologic events. So you want to get the headache early before it affects the entire trigeminal nerve, and then you get the secondary vascular. This used to be called a vascular headache during my training years, and it really is not. Migraine is a neurologic event that then becomes a vascular secondary event. So therefore, early intervention is quite useful. So common themes. Headaches are common, and they are rarely cause for alarm, except red flags. You've heard red flags. I'm going to leave you could look at this slide, but you can read through them. Sudden, explosive. Headaches are associated with fever, meningeal signs. Headaches associated with mental status change. Headaches that awaken patients from sleep can be migraine. Migraine may occur more periodically in sleep, but that is considered a red flag. Headaches associated with true syncope, with vertigo, with any abnormal neurologic exam, headaches that are associated with elevated blood pressure, and don't forget to palpate that temporal artery. It may be present. Temporal arteritis is not that rare. It's associated with polymyalgia rheumatica, and again is part of a reasonable exam that your patient deserves to have in terms of making a diagnosis, because management is quite different. Routine analgesic medications promote and perpetuate headaches. This is called rebound headache or medication overuse headache. And opioids are major culprits, and use of these drugs prevent the preventative medications from working. So using muscle relaxers, using regular acetaminophen, using opioids will make chronic headaches worse through direct pharmacological triggering of the headache event. Social and psychological factors typically trump in a primary care practice the biological mechanisms that are driving the headache. I've commented in a somewhat sarcastic fashion, but some of the best treatments for headache in my primary care career has been a spousectomy procedure, which means that the very important relationship in the patient's life may not be satisfactory, could be frankly abusive or just not meeting needs, and this will help drive headaches, and it really means you're going to need to get down in the weeds a little bit with the patient about how is life going and how are things going in their relationship. And that, again, very well suited for primary care providers, and sometimes will need specialized psychological support. Preventative therapies are crucial. Sleep deprivation, very well known to trigger migraines and promote chronic daily headaches. Diet hygiene, and that includes no monosodium glutamate. Don't forget, MSG amplifies our taste buds, increases sensitization of taste buds, and it also increases sensitization to headache. High glycemic diets do show some increase in inflammatory markers in the interleukin pathways, and therefore high glucose loading is not a good idea, and general fitness is a valuable treatment. It helps sleep, it helps mood, it helps sense of well-being, and it helps headache. And pharmacological management plays a role, particularly with migraine. So again, avoiding triggers, avoid sleep deprivation, improves self-management regarding stress. Our cognitive behavioral therapy, biofeedback, and relaxation, again, very helpful, particularly for the tension headaches and for chronic daily headaches. Patients are often fearful of stopping medicines that are actually promoting the headache, and they don't know what they're going to do because of catastrophizing. How can I manage without these medicines? And that's hard work, counseling patients, and I have the luxury, although our wait list is too long, the time to get to see our behavioral therapist here is excessive. This is where your behavioral support may play a very, very important role in explaining from a non-medical provider why it is important. It's not about the medicines. It's about relaxing and not being fearful that the medicines are required. A colleague of mine from years ago, Dr. Stuart Tepper, now at Cleveland Clinic, taught me this, and I actually believe in it still. If you're using over-the-counter analgesics, this is the Excedrins, the acetaminophen, the periodic medications. If you can stay less than 10 doses a month, you won't trigger medication overuse headache. This was an off-the-cuff remark, and I've used it for 20 years, and I think he's onto something. So it's okay, but limit the frequency so you don't trigger the daily headache. NSAIDs probably get a free pass on medication overuse headache. Naproxen has been most looked at and maybe least of a culprit. Ibuprofen shows some data to support that it can continue to perpetuate headaches, but the bulk of the literature supports NSAIDs are appropriate, but I would look to managing headaches with NSAIDs if there is a trigger such as an underlying migraine that's then causing this vasoactive response, the neurogenic inflammation response. There's evidence for magnesium, for feverfew, and riboflavin. These are available over the counter. There's some combination products. Triptans or DHE, ergots, dihydroergotamine, plays a role. If the headache's less than 10 a month, The insurance companies are not going to let you give it to patients more than 8 times a month, and that's valid to the degree that if they're occurring that frequently, you need to be on a preventative headache therapy such as beta blockers, anticonvulsant drugs, and or antidepressant drugs, especially when depression, anxiety are co-occurring, and sedating antidepressant drugs, particularly of the tricyclic class, when sleep management will be benefited by them. Temporomandibular disease, don't forget oral appliances play a role, and also TMD is part of the central sensitization sequence, pain referring into the temporomandibular joint when there's no active disease in that joint any longer. Again, becomes more complicated. Neuropathic pain, you'll see this in your primary care practice. Common, certainly with metabolic, i.e. diabetes. You'll see it in carpal tunnel syndrome, ulnar nerve impingement syndromes, and post-herpetic herpes simplex virus, shingles, varicella zoster virus, common with HIV disease, and Lyme disease produces a spirochetal neuropathy. Post-chemotherapy for cancer survivor patients, it's a rather refractory peripheral neuropathy. And then craniofacial or trigeminal neuralgia, which is, unlike migraine, it doesn't require a periaqueductal gray trigger. It triggers right from the trigeminal nerve. And again, is episodic, not constant and continuous. Common themes, make the diagnosis. If there's peripheral neuropathy, rule out diabetes, B12 deficiency, thyroid disease, autoimmune disease. Careful exam. We just saw a case coming in as carpal tunnel syndrome into the clinic, evaluated by a couple of people who should know better, and there was no carpal tunnel. I don't know where. They liked the idea of carpal tunnel, nothing to support it. Did a good neck exam, classic radiculopathy into C8. Had nothing to do with the carpal tunnel pathology. So the clinical exam is, again, the most important thing. Do a careful exam. Neuropathy is often idiopathic.
Yes, C6 is the thing that most mimics carpal tunnel.
Yeah, and that's the the AOK sign. That's C6. So, you can remember 6. It looks like a 6. Easy mnemonic. That's your carpal tunnel. So the C6 dermatome is even the wrong dermatome. So make the diagnosis and treat the patient correctly. This woman, we went with some physical therapy for her neck, and Dr. Rapp is going to be seeing her for some trigger point injections because she's got a lot of myofascial pain that's referring down. But this has nothing to do with carpal tunnel, and she was off to see a hand surgeon. Who knows where that would have gone. Most of the drugs we use in general have less than 30% reduction in pain intensity, so therefore the psychological and social factors need to be pursued. Quality of life and activity is crucial to overcome this sedentary, disengaged, asocial, depressing, and demoralizing life that neuropathic pain can contribute to. Chronic opiates have been looked at. They're about as effective as non-opioid drug therapies, the gabapentinoids and the antidepressants. However, they have their own problems associated, including hyperalgesia in response, promotion of central sensitization in response, and all the risks of misuse and abuse. So they are reasonable in carefully selected patients. The drugs we use, tricyclics, serotonin nonspecific reuptake inhibitors, anticonvulsant drugs, the calcium and or sodium channel blockers. Calcium blockers refer to gabapentin and Lyrica, or pregabalin. The sodium channel blockers are Tegretol, carbamazepine, that we use for trigeminal neuralgia. The topical lidocaine, capsaicin may play a role. If vitamin deficiencies are present, supplement them. And low dose, when all else fails, an opiate trial would be reasonable if the patient is a suitable candidate. And if there's no benefit that's sustained, take them off because the evidence is absent for long-term opioid benefits in the management of neuropathic pain syndrome. Part of it is there haven't been good studies, but the other part is the body, particularly the nervous system, and we're dealing with the nervous system in neuropathic pain, is plastic, and with chronic exposure to the opioids, the nervous system works around them and diminishes the response. It used to be called tolerance. It's more than tolerance. It's neuroplasticity that's involved. Abdominal pain syndromes, Just a few more minutes. They're listed here: irritable bowel, inflammatory bowel, endometriosis, interstitial cystitis, and male pelvic pain or prostatitis or prostadinia syndromes. Again, fairly common. This is very similar to what I said before. Make a diagnosis. For chronic pelvic pain and chronic abdominal pain, if there are adhesions, don't operate, don't recommend surgery unless there's an obstruction present. Evidence supports only with a documented obstruction will you benefit a patient by lysis of adhesions. Visceral hyperalgesia, which means pain independent of responding excessively, I should say, to non-noxious activity such as peristalsis, such as bladder voiding. When that hurts, that's visceral hyperalgesia, and that is a central sensitization syndrome. Chronic opioids worsen this syndrome almost uniformly. Episodic pain tends to promote dose escalations, and then you're on the ladder of increasing opioid doses. And the opioid anticholinergic side effects tend to exacerbate symptoms, such as gastroparesis, bowel and bladder dysmotility, which is also part of the problem. Again, social and psychological factors trigger, and flare management, again, it is important in your treatment planning because the patient needs a non-pharmacological strategy. Otherwise, they'll be back in your office or back in the ED or back hospitalized with flares. And a plan in place typically will be one that's generated by someone from the behavioral health specialty. Treatments are almost identical for these three syndromes. And so I'll just, in summary, best therapies for all and current guideline recommendations for irritable bowel, interstitial cystitis, and chronic pelvic pain are cognitive behavioral therapy, tricyclics, and or gabapentinoids. Period. We don't see any other specific therapies that offer substantial relief, and I clump these together as a syndrome that is going to pull out the same prescriptive order that I'm going to offer. For pelvic pain, of course, you make the diagnosis. If there's endometriosis, that needs to be treated. But again, if the pain persists and we don't have active nociception, we resort back to CBT, gabapentinoids, and TCAs or SNRIs. And or multidisciplinary pain care if that's accessible for you. Myofascial pain and fibromyalgia, widespread pain conditions. Again, the same as I just said before. So interstitial cystitis, irritable bowel syndrome, I describe this to my patients as fibromyalgia of the bladder or fibromyalgia of the bowel because the mechanisms appear to be the same. They're driven by brain, not peripheral injury processes, but by central sensitization processes. So you get aerobic, get the CBT, improve diet, and the original strategies identified before. And on the right of the slide, you can see tricyclics, SNRIs, anticonvulsant drugs, and rarely, if ever, opioids. For specific focal myofascial pain, intramuscular stimulation, trigger point injections, and structured physical therapy directed toward that area also play a significant role. So in conclusion, and I took more time, but we just have one case, so I took the luxury of that. I apologize to my colleagues running over here. All chronic pain is complex, even though it looks simple. The patient's experience with the chronic illness has to be understood. Co-occurring conditions and risks and side effects of all management are critically important. Make the diagnosis. Is it acute, chronic? Is it incidental? Is it nociceptive? Is it neuropathic? Is it mixed? Again, it is very important not to have a chronic pain as your diagnosis. Our current ICD-10 will not allow me to associate chronic pain with a billable code. So you may be thwarted by that, you may not be, but heads up, it's not considered an adequate diagnosis. You need to identify the type of pain, at least by location, and best by some further characteristics. And all the meds we do, it's probably less than 30% benefit, so we need more than meds. Okay, why don't we have a couple of questions. Let's go down, can we just scroll down to Leighton Jump? I'm going to come back up to you, Sharon, in a minute. How is discogenic pain different from radicular pain? Is discogenic pain the rare discitis case? Leighton and Karen, you guys are just great. You always nail me because discogenic pain is very, very controversial. And I'm going to just say I use discogenic pain when I can't find anything else to explain it. And it appears that movement across the disc space is triggering the process. So discogenic pain means it's not radicular. So that would be radicular pain, radiculopathy. So it's axial pain. It can refer out a bit into the soft tissues, but it gets in the murky land of what do we mean. Unfortunately, I have Dr. Robinson here. Can you get me out of the jam I'm in right now?
Because it's interesting. Here you are at the University of Washington, under the big shadow of Drift Dale.
Yes.
And of course, there is a whole group of people who would use the term non-specific low back pain because we have such a hard time identifying a pain generator in axial spinal pain. And they've tried. They've tried discograms. They've tried intradiscal steroid injections. Anything. In other words, I tend to agree that a young person, for example, who has trouble with flexion activity, sitting and bending, that probably it is a disc, but we have been so spectacularly unsuccessful in proving that I would say it's axial spinal pain, and we're not sure of the pain generator.
Okay, so this is going to prompt me. Yeah. I apologize. I didn't edit my slides recently. Yeah. I'm going to take that out because it's confusing. And discogenic pain probably is non-specific low back pain, which maybe is much muscular and fascial, but we don't know.
And despite billions of dollars spent, we have not been able in a really clear way to nail that down. I mean, there are some things, and Susie's here and can speak to the interventionalists who tout, identifying facet joint-mediated pain. That's, if you look at the American Pain Society review of that, John Lozier's big, heavy footprint, they did not feel that it was really well established. If you look at the people who are in the interventional field, they say it's the greatest thing since sliced bread. But even that is a minority. Nick Bogduk, who was the godfather of all interventional therapies, said it's very rare to find facet-mediated pain in the lumbar spine. So discogenic pain, I think a lot of us believe in, but we can't prove. Facet-mediated pain, we also, some of us believe in, but that's hard to prove, or maybe a little better than discogenic, but not much. Most of the time, we don't make a definite diagnosis.
Yeah, all right. So thank you. I will clear that out. And then your follow-up question, is it reasonable to use cyclobenzaprine to help sleep combined with nortriptyline for pain modulation? I would answer no, because if this nortriptyline isn't helping sleep, I would flip them to amitriptyline, which is essentially a cyclobenzaprine, because you're going to get at least the proven antidepressant effects as well. And then you're mixing two tricyclic drugs, and that's beginning to get into confusing polypharmacy. So I don't think you'd add sertraline on top of fluoxetine, Zoloft and Prozac together. And I would say adding cyclobenzaprine to nortriptyline is adding one TCA to another. Some patients won't take a tricyclic because I don't want you messing with my mind, and they'll look it up and it's an antidepressant. I have been known to resort to cyclobenzaprine as an alternative to a tricyclic because when they look it up, it's a muscle relaxant. And I think that's not lying. That's just moving towards the most adequate therapy
pseudoscience
I can provide, right? But it's again another potential strategy. And Deborah Dom's a patient on 3 grams a day of gabapentin for over a year, symptomatic with neuropathic foot pain. How do you transition onto amitriptyline? I'm starting with 25 milligrams at bedtime. Sleep is a major issue. Exactly right. So you're adding a tricyclic, which is strong evidence-based support for neuropathic pain, particularly in the foot. Could be diabetic. Let's just suppose that's the case. And at full therapeutic dose of gabapentin, not in effect, adding a second drug of a different category. So we're adding to a calcium channel modulator, an anticonvulsant drug. You're adding a tricyclic antidepressant drug. And amitriptyline is a good choice. 25 milligrams, maybe a big dose to start.
Definitely a big dose. I once tried that. I took 25 milligrams of amitriptyline because when I was doing my psychiatry residency, What's good for the goose is good for the gander. I was not fully conscious for 24 hours. So the notion of starting person on 25, I would say, don't do that.
I usually start Deborah on 10. If you're already on 25, you can get away with it. But so your patient doesn't become allergic to amitriptyline, which is what they'll say, and they'll never take it again. It's always easier to start low. There's no foot race on that. All right, let's do roll call. We'll get into it. We have a case. We have folks from Peace Health. And Sharon, I'll be able to address your questions as we move forward here.
Sharon is going to be heading to clinic, so if you
Okay.
could address her
All right.
questions now.
All right. So, Dr. Mulvihill, thank you. You got to get back to clinic. You're reviewing the new CDC guideline draft for opioid prescribing. Bravo. One comment is comment on it. Go online, add your comment. I won't tell you what you should think, but it's a lot like what we have in Washington State, and I think it's pretty darn good. But you write your opinion. They're going to basically count how many positives versus negatives. So every vote counts on this. And I wouldn't say vote, but any comment would be very helpful. It seems to be much more conservative, and can we have a telehealth discussion on this? It is a bit more conservative. The final draft is not complete, and I think let's plan on this discussion, and we can maybe even plan when Dr. Ballantyne is in town, because she was one of the
March is when she's in town.
March. All right, we'll work on discussing. I'm very familiar with both guidelines, having been involved in both. We can have a chat about that, but let's see what the final version is after the public comments are. But they are more conservative, basically on dosing limit and on how many days you can give opioids after an acute setting. So they say 3 days. I'm not sure that's practical. And they're recommending stopping at 50 and really stopping by 90 milligram equivalent. And we had a lot of discussion about that. Could be right, it may be right, but it's awful hard in real life practice to meet guidelines, and that's going to derail the effort, which is to get everyone into guideline compliance. How do others limit the percentage of chronic pain in primary care practice, especially in scheduled with residents? Sharon, that's a tough one. I know at the General Internal Medicine Clinic has a cap. They see only 10%. They keep a registry in their clinic. So if you're in a teaching clinic, they say we 10% of the time we will deal with chronic pain, but there's so many other issues in our training program that we don't want to be bogged down in that. So they just set a pure population cap. I don't really like the idea, but I'm not the medical director of their clinic, and I understand the challenges that they have. Sharon had another question about the cannabinoids. Do we still have that? I saw.
Different day.
Sharon, you also had a question about co-prescribing opioids and patients on cannabis or marijuana. Complicated. Bottom line, in this clinic here, based on the Assistant Attorney General's review of federal law, there's no prohibition because the drug is not an illegal drug in this state. It's complicated. And again, worth another more complicated discussion about that. But I don't have a prohibition. I know some clinics do. I've reviewed. No, that's not the one.
We're seeing more patients with positive
THC on the urine drug test. So we are seeing more patients with positive THC on the urine drug studies. And in the past, we've told them that we would not provide opioids to patients using marijuana. Is this changing as it becomes more acceptable in the legal arena across several states? It's still a complicated issue. I got into a mano with a doc who said, I'm not going to risk my license because federal and state regulations are ambivalent on this. I think if you're concerned about protecting your license, you can be very cautious. I'm concerned about protecting my license, and I'm co-prescribing. So it's going to be your own threshold. I expect my patients using cannabis and they're using opioids to be at half the dose that they're on. So, you're on cannabis, I'll bring you down 50%. Why? Because it's good to be down on 50%.
And there's an additive effect, at least.
There may be an additive effect. We do know that states that have medical cannabis laws have about 50% of the overdose deaths on a population basis. Is that related to people being happier stoned on cannabis than being overloaded on opioids? Is it safer to be on cannabis than opioids? Driving accidents, maybe not, but overdose deaths, yes. It's a subject that we can't comment on. The American Academy of Pain Medicine, Palm Springs, for those of you who want to get a little sun in the middle of February 19th through 21st. There's going to be a discussion there. The American Pain Society, there's going to be a discussion also about cannabis. It's a hot topic in the field of pain and a relevant one in discussion with your patients.